This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Gregg from Mayo Clinic in Jacksonville, Florida. Today, I have the pleasure of interviewing Tom Montine and Brenna Cholerton, neuropathologist and neuropsychologist from Stanford, and co-authors on a paper published in Neurology exploring the neuropathologic burden in dementia in Nonagenarians and Centenarians. Tom and Brenna, thanks for joining me today.
Oh, thank you, Gregg.
Thank you, Gregg.
It seems almost obligatory if we're going to open a paper or a podcast on dementia, we're going to remind our audience that people are 1, living longer, 2, population demographics are shifting, and 3, more and more people are at risk for age-associated neurodegenerative diseases and cognitive impairment. But your paper, the one that we get to discuss today, says it might be more complicated than that. That is that while neuropathology does indeed build up and accrue with age, increasing age may actually shift the relationship between neuropathology and dementia. Let's hear from you. Why is it important to tease apart the contributions to this dynamic association? And a follow-up, what underpins your interest in dissecting these relationships in the oldest old individuals?
So Brenna and I, along with close colleagues Lon White and Eric Larson, have been using neuropathological data from community cohorts to try to understand what is the relative importance of different contributors to cognitive impairment and dementia as we get older. And one of the things we noticed some years ago in work that we had done in different community cohorts is that the answers we were getting varied, sometimes a little bit, sometimes more than a little bit. And so the question that arose was, how generalizable are the findings from these different individual cohorts? To what extent are the differences driven by inclusion-exclusion criteria of the different cohorts, assessment differences, whether they're clinical, psychological, pathological, how much of the differences and similarities are real? So we have, for a number of years now, been jointly analyzing the data from multiple community-based cohorts, the ACT study in Seattle, the Honolulu Heart Study, Honolulu, the NUN study in the Midwest, and then the 90-plus study in Southern California. The focus of the paper was on this issue of what some people call the oldest old, or people over 90. And there were 2 of those cohorts, the ACT study in Seattle and the 90-plus study in Southern California, that give us line of sight into this group of nonagenarians and centenarians, the rapidly growing subset of the population in the United States.
We've been very fortunate to have all of these different cohorts to compare, and it was really exciting to be able to take a look at these 2 different cohorts that had such a large group of people who were 90 plus. It just isn't a group that we know or have known a lot about to date.
Well, let me ask you to summarize. What are the key findings from the paper in this really exceptional group of participants?
We really had 2 main questions for this particular paper, and those were there differences between the groups in terms of the amount of the most common neuropathologic changes that are associated with aging and dementia? And also, were there differences in the impact that these changes had in the presence of dementia diagnosis? So we found that participants in the 2 older cohorts did differ in the amount and type of neuropathologic change. So the adult changes in thought participants had a higher burden of microvascular brain injury and also limbic predominant age-related TDP-43 encephalopathy, which we will refer to as late to make it easy, as well as total neuropathologic burden. And then the 90-plus study participants had slightly higher levels of Alzheimer's disease-related neuropathologic change. So we then estimated what the impact of eliminating the specific neuropathologic changes on dementia prevalence would be theoretically. And we found that while across the board, eliminating Alzheimer's neuropathologic changes would be beneficial, there were differences in the other diseases. So we found that eliminating microvascular brain injury would theoretically reduce dementia pretty substantially in the younger group, but would actually have little to no impact in either of the older groups. And then meanwhile, late seemed to play a more prominent role in dementia in the 90 plus study participants than in either of the other groups.
Tom, I'm not going to call you out on age here in this field, but you've been doing this work for some time. Any of these findings surprise you?
Yeah, I think the biggest surprise to me was what Brenna just described for a small vessel injury to brain, which is replicated in many cohorts around the world as a contributor to cognitive impairment and dementia as we get older. But this striking difference in the cohorts that was the attributable risk to dementia was substantial. As I recall, 20-ish, 25-ish%, meaning that if statistically, like if we could wave a magic wand and make it disappear, how much dementia would disappear from the population? That's a sizable chunk. Yet in individuals over 90, that risk appears to drop off dramatically. And there's data collected from different perspectives, but there's other data on this issue that supports this notion that the contribution of vascular injury to cognitive impairment and dementia in the oldest old is less than in people in their 70s and 80s.
And the follow-up to that then, I think, transitions quite nicely, but how do we take these findings in a pretty unique cohort and a very interesting group of people and translate that back to clinical practice? So for the neurologists listening, the other practitioners that follow along with us, what advice or how do we use these findings to change the advice that we're providing to our aging cohorts in practice?
Yeah, I think that it's really going to be important in these older age groups to, while we know and we understand from many other studies that if we were to reduce microvascular burden in the general population, we would also reduce dementia. Since this doesn't seem to be the case in this older group, I think we really need to be looking at other focuses and other approaches for individuals that we can use to enhance resilience and to reduce dementia in this older group. So things like maintaining or improving social support, cognitive enrichment, and physical exercise. All of those we do know continue to be very important in reducing dementia well into the older ages.
Another point to consider from these data is that as the field moves towards biomarker-assisted diagnosis of disease, what we observe pathologically is that as individuals age, especially within the context of the 90-plus cohort, there's a high percentage of cognitively normal individuals. And if I can just underscore there, these are not individuals who seem to be cognitively normal. They've been through rigorous neuropsychological testing, medical evaluation. They are high performing, yet pathologically, they have the markers of several of these diseases often in their brain. So as we transition to this future of biomarker-assisted diagnosis, it's not going to be as simple as the biomarker is positive, so that means we treat, because it's clear that many people can be resilient to the clinical expression of these diseases well into old age.
I think that clinical practice point bears repeating. It's really on those of us that order these tests to be reflecting on what we're going to do with the results and know our pretest probability. So as your work is showing, these disorders become increasingly common in older individuals, multiple neuropathology increasingly common in older individuals, but we need to understand the effect and the relationship between that and the end clinical points that we're targeting, most often cognitive impairment. And thank you for bringing that to the forefront. I'm going to follow up a little bit on some of what we were just talking about. And if vascular disease has less of an effect, perhaps in our 90, 95 plus group, do we then tell people to eat more salt, enjoy that sugar, go out and enjoy themselves, and hoping, of course, that's going to lead to better social engagement, reduce loneliness, and keep people doing enriching activities? Is that a reasonable take-home that I can share with my patients? They'll be happy to hear it.
Well, there's a fine line. You certainly want to maintain good physical health. I think the take home is that, as Tom mentioned, other studies have also supported this, that perhaps hypertension, hyperlipidemia just aren't as important of a target as maybe increasing social support, cognitive enrichment.
This is all in the context of individuals who have lived through whatever the ensemble is of their life experiences. They've lived into their 90s and beyond. You don't know who's going to live that long, right? So when you're trying to manage the care of a 70-year-old, I think you obviously need to be committed to good cardiovascular health, maybe less aggressively so once someone survives into their 90s.
And as your data does show, vascular risk factors still matter, particularly in younger individuals, and younger in this context being in the 60s and 70s and perhaps even into the 80s.
Yes, absolutely.
That does fit with how I like to provide advice when I'm finished counseling, and particularly when I'm counseling my super ager patients, those who I aspire to be like. I usually add the qualifier that when I'm 80, I'm certainly not listening to a 40-year-old. So there's something we can learn from talking to our patients about what's gotten them to this stage in life. Obviously, a lot we can learn from the pathology as well. On that note, this autopsy cohort really does offer some incredible advantages when we're targeting the questions that you've brought forward here, allowing us to assess, quantify pathology. You're using state-of-the-art techniques and continuing to guide and shape what we do in the field across all of our centers with the work that comes from your center. But of course, also subject to limitations. We're discussing some of those in terms of the unique selection bias that goes into taking people that survive into older age, but also some, I think, important caveats here when we're thinking about the demographics and representation and geography of the work that's done here. What are the important points here, the caveats that you want to communicate to the listener that we should be keeping in mind as we interpret findings from this study?
Well, I think, as you mentioned, that we're comparing two different cohorts that had different selection criteria, different study methods, different visit intervals. All of those things can impact the differences that we're seeing, different pathologists reading the slides. However, as you also mentioned, these cohorts are typical and sort of suffer from a known problem in research that is an overall lack of racial diversity. And that certainly can limit the generalizability of the results. And so I think moving forward, the work that's being done in the field to improve diversity so that we can make sure that we're disseminating results that really do reflect the community as a whole, I think will be really important.
So I mentioned at the beginning some of these other population or community-based studies that Brenna and I and others have been involved in. So for example, the NUN study is all women, mostly from Midwest and Southeast United States. The Honolulu Asian Aging Study is all men of Japanese descent. And then the two studies that we're talking about here today, the ACT study and the 90+ study, are men and women, but all on the west coast of the United States. So we think there's value in comparing across these different cohorts. So for example, one thing what we've seen across all of them is that without question, the burden of Alzheimer's disease is the strongest predictor of cognitive impairment and dementia. And we immediately went to where we see differences in these groups around vascular injury and this entity called LATE. And that's important to consider because especially in this older group, as we develop effective therapies for Alzheimer's disease, I think it's entirely appropriate. That's our first major target. Many of these individuals will continue to be challenged by these other diseases that are in their brain. So Alzheimer's disease is the major target for therapeutic development. But as we're successful there, we need to be prepared that in older individuals, it may be less effective in reducing their cognitive impairment because these people so commonly have multiple contributors.
And of course, Alzheimer's doesn't care about your race, ethnicity, or gender. It affects us all and is a unifying point to focus around. I like that call to action, and certainly one that we endorse on the podcast and at AAN, a real priority issue, making sure that we're doing research that matters and providing care that matters to everyone. What do you see as future work in this cohort?
I would say that the good news is that, as Tom mentioned, there is a high rate of resilience among people who survive into their 90s and beyond. And we have so much to learn from these people. So I think really continuing to explore what factors allow people to live dementia-free into their 90s and how this might inform interventions in younger people who are at risk for dementia. In the oldest old, I think it's important to explore how we can continue to best support resilience.
So I do think, as Brenna was saying in her previous comments, it will be important for this approach to be expanded to more diverse populations around the globe. And I hope that information is useful to patients and their physicians. So that's one future prospect, expand this approach. And the other is that where we're focused is that through this work, we identify a subset of individuals who are what we call resistant, meaning despite living to the 90s or even into their hundreds, carrying some amount of genetic risk. So high load from aging, at least moderate load from genetic risk. They're rare, but these individuals have none of these pathologic changes in their brain. So there is a major clue from that clinical pathological correlation that these diseases are preventable. I don't know how they were prevented in those individuals, but they are preventable. And then the second, as Brenna just talked about, are the resilient individuals. They're more common, but that group proves that these diseases are all treatable. And we don't know how to treat them yet, but it shows that you can carry the high burden of these diseases in your brain without clinical expression. And so we're very interested in trying to, as Brenna said, try to follow those, I think, very meaningful clinical pathological correlations and translate that into therapeutics.
I'm envisioning listeners everywhere leaning in for that discussion here on resilience and on resistance, on these key factors as we work together to try to unlock the holy grail here, allowing us all to age a little bit better despite pathology, or in the best case scenario, without pathology. Great goals to try to achieve. And of course, work that does require this incredible collaboration that the both of you have between neuropathology, neuropsychology, clinical colleagues throughout life working on dynamic teams at multiple centers with representative populations. So fantastic work. Thank you both for taking time to speak with me about this. Really appreciate that.
That's a great pleasure. Thank you, Gregg.
Thank you, Gregg.
I've been speaking with Tom Montine and Brenna Cholerton, authors on the paper titled Neuropathologic Burden and Dementia in Nonagenarians and Centenarians, which you can and should read in Neurology.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.